intensive care to neonatal intensive care that consisting of three interesting topics. Please give me a giving warm welcome to the session moderator, د.رقية العلي. د.رقية العلي is a neonatologist consultant and neonatal prenatal fellowship program director at Maternity and Children Hospital in الأحساء.
Assalamu alaikum. Good morning, everybody. My deep thanks to the organizing committee for invitation and for the great organization of this event. We'll go directly for our speaker, our first speaker, to save time, د.طلال التميمي. He is a neonatologist, finished his pediatric residency program here in Saudi Arabia. Then he had his fellowship in neonatal prenatal medicine from Western University in Canada. Also, he is specialized in neonatal hemodynamics and point of care ultrasounds applications in the neonates. د.طلال التميمي currently works in Women Health Hospital in National Guard Hospital in King Abdulaziz Medical City in Riyadh. He has a couple of researches and his interest in chronic pulmonary hypertension in neonate and ultrasound guided vascular access. Welcome with me for د.طلال.
Assalamu alaikum. Thank you very much for the invitation. I'm very happy to be here in Al-Hassa. I'll be talking about pulmonary hypertension in newborns, one size fits all. And the reason why I chose this topic specifically is because of a challenging case of pulmonary hypertension and a colleague of mine who is a pediatric cardiologist. I was going through the history with him, and he interrupted me without me completing the history and told me just start nitric oxide. And not asking for more details, not asking about the echo or anything. And I thought at that stage, this is a good opportunity to talk a little bit more about different types of pulmonary hypertension, and is one size fits all, or it's a bit different. So I have nothing to disclose. So newborn babies are predisposed to pulmonary hypertension, and we know that preterm babies are even more prone for pulmonary hypertension. The transition from intrauterine to extrauterine life, many steps goes on, and the pulmonary vascular resistance drops. The transition is quite, normal or acceptable in term babies, but it is a bit complicated in preterm babies. Their pulmonary vascular resistance may not go down as much as term babies, and even with our interventions postnatally, like ventilation, which is very necessary for them, infection, so on and so forth, can increase your pulmonary vascular resistance. And with time, with all of those interventions, you will lead to a stage where you have pulmonary bronchopulmonary dysplasia, which is associated with high pulmonary vascular resistance. And this can continue lifelong, actually. Yeah, I think this is better. Okay, so for many causes, either in utero or after the transition extrauterine, so neonatal causes like meconium, aspiration, respiratory distress, so on and so forth, and also in utero factors like hypoxia, whatever it is, pulmonary hypoplasia can increase your pulmonary vascular resistance. And this causes a vicious cycle of pulmonary hypertension. Pulmonary vascular resistance increases. This causes a degree of reduced pulmonary blood flow to the lungs because of increased afterload to the right ventricle. This will lead to a decreased left atrial filling, decreased preload at the left ventricle, and therefore you will reach to a stage where there is low cardiac output state. This will lead the baby to have anaerobic metabolism because of poor perfusion and acidosis. This acidosis will increase the pulmonary vascular resistance. The shunting will become right to left even more, and you have you know, this vicious cycle just continues on. And it also has consequences on the blood pressure. So you have increased pulmonary hypertension, increased afterload to the right ventricle, and more strain to the right ventricle. You have decreased pulmonary flow, decreased left atrial filling, hypoxia, acidosis, decreased LV preload, decreased cardiac output, and hypotension. So it does affect, you know, having the cycle of pulmonary hypertension. If it's not broken, it's just going to make things worse. So to understand the etiology, and I think this is very important, we have to just remember the formula for blood pressure in general, even the systemic blood pressure. So blood pressure is cardiac output multiplied by the peripheral vascular resistance, or the vascular resistance, SVR. It's the same thing for the pulmonary circulation. So pulmonary circulation is mean pulmonary artery pressure equals the cardiac output multiplied by the pulmonary vascular resistance. But we add one more thing to it, which is the pulmonary venous pressure, which is the pressure that is from the left atrium all the way back through the pulmonary veins to the lungs. And this is quite important, because if we understand each component from this formula, and we increase or decrease any of those variables, we will increase the chances of pulmonary hypertension. So for example, if we have a case where there is a lot of flow to the lungs, like for example a PDA that is left to right, or we have a large ASD that, you know, pushes a lot of flow to the lungs, eventually the pulmonary vascular resistance is going to increase because of a lot of remodeling in the vessels, because of this edema. Same thing that happens with our increased PVR. You know, classically we have RDS, BBD, so on and so forth. This increases the pulmonary vascular resistance. And this is the classical way of we think of pulmonary hypertension. But there is also another phenotype, which is the post-capillary, which is, you know, coming from the left ventricle or the left atrium, going all the way up to the lungs. So this is one of the important phenotypes that we'll be discussing today as well. LV dysfunction, either systolic or diastolic, also having left atrial hypertension and pulmonary venous stenosis are one of the important causes here. Okay, so just to save time, let's نرجع للسلايد اللي قبلها. So an easy way to think about pulmonary hypertension for us neonatologists is to look at it from the time that it occurs. And an easy way to subcategorize it is, when does it occur? Is it an early occurrence within the first 72 hours of life? Or it's a little bit later, a late occurrence from 3 days of life up to maybe 2 weeks? Or it's something later than that. And that, you know, can easily subcategorize the phenotype and make it easier for, can you go back please? No. No. No, no, no. Okay, so for the early causes, no. نرجع ورا معليش. No, 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 this is too far. More, more, more. More. Okay. Yeah, continue again. شغال شكرا. Okay. So for the first 3 days, we know that the increase of nitric oxide use is happening, although there is a statement that came out in 2011 saying that routine use of nitric oxide is not recommended, especially for those babies that are preterm. And even if you look at the Canadian Pediatric Society, routine use is not recommended. It can be used in cases where there is pulmonary hypoplasia associated with oligohydramnios. But since that statement until now, we can see in different countries, including the US, Canada, and the UK, that the use of nitric oxide is on the rise. And even if we look at it here in those babies less than 26 weeks, it's even higher. And those are considered to be one of the highest risk babies. And we know that there is some association between prophylactic use of nitric oxide and the occurrence of IVH. And this is a problem. So if the statement says that we shouldn't routinely use it, but we are using it a lot, are we really providing the best care for the patients? Are we increasing the risk of having complications as IVH? Are we really benefiting those babies from giving them a therapy that they are not really benefiting from? There is a missing slide, Tara. So there is a missing slide here, but I will just go on with it. So the slide was looking at the use of nitric oxide in Japan, where they looked at babies that are less than 32 weeks in comparison to babies above 32 weeks. And it seems that those babies that are less than 32 weeks actually had a better response to nitric oxide, especially in the first 3 days of life. And the same thing was done in the US in a study, retrospective study for the patent registry. They looked at babies that are preterm, around less than 32 weeks as well, and the time that they started nitric oxide, if there is any improvement in the FiO2 requirement. Those babies actually that were smaller had a better response. So we have data that they actually respond really well. So let's go on to the next category, which is from 3 days of life up to 14 days. Those babies are not born with pulmonary hypertension, but they had an event after that that made it complicated and increased the pulmonary pressure. For example, they had an infection or they had a pulmonary hemorrhage. And they also have an element of ventilator-induced lung injury. So there is an element there of early BBD changes. And let's see what does the evidence say about this. For after 3 days to around 2 weeks of life, I think one of the landmark works was done by Amish Jain in Mount Sinai. What he looked at is those babies that are considered to have pulmonary hypertension, but they were after 3 days of life up to 2 weeks, and he looked at babies that are septic and diagnosed with pulmonary hypertension, and was also started at nitric oxide. Those babies that responded are much less, around 20% less than those babies in the first 72 hours of life. And their mortality was higher, it was around 44%. So this tells us that those babies that are a little bit big and they have pulmonary hypertension, they are less likely to respond to nitric oxide, maybe because they have a different physiology. So until they fix this, I'll just ask a few questions. So how many of you here, if you have a baby that is probably 1 hour old, 24-weeker, FiO2 is around 80 to 90% on high frequency, you would consider starting nitric oxide? Please raise your hand if you will. So we don't see a lot of hands being raised here. Okay, very good. Okay, so this is the study that we were talking about. So that the FiO2 and there was not a lot of changes in those babies that were septic, and the pulmonary hypertension phenotype in those late occurrences is a little bit different. Now let's focus on the other entity, which is chronic pulmonary hypertension, those babies that have BBD. So we know that the overall incidence of pulmonary hypertension in babies with BBD is around 4% in all of those babies, and it kind of doubles if babies are diagnosed with moderate pulmonary hypertension. But if they have severe, it's around 40%, and that's a big number. So almost half of those babies with severe pulmonary hypertension will have, with those babies with severe BBD will have pulmonary hypertension. And this is also very important because we know their outcome is also not really good. So this meta-analysis looked at survival of those babies if they have BBD, and the mortality is around 18.9, so around 20% mortality if they have pulmonary hypertension with severe BBD. So 1 in 5 may actually not make it if they are diagnosed with pulmonary hypertension. And this is also very important that even after discharge and following up later on. So the chances of them still having pulmonary hypertension at 1 year of age is around 20%. and the chances of them, survival is goes down very much. The mortality goes up to around 30% at 1 year of age. So you have a lot of proportion of those babies that will not make it to their first birthday. So this makes us think that, can we do anything to reduce this risk? Is there any intervention as neonatologists we can do to reduce the mortality and the complications of pulmonary hypertension? So there is. It has been there for a long time, the screening for chronic pulmonary hypertension in those babies. You have the American guidelines, you have Canadian as well, there is the European guidelines. So what in the American Heart Association and American Thoracic Society joint guidelines say, screening for pulmonary hypertension by echocardiogram is recommended with babies with established bronchopulmonary dysplasia. The European guidelines is quite clear. They put on a very nice algorithm of when to screen, how to screen, and what medication that you're going to start. In National Guard, we implemented this chronic pulmonary hypertension screening program where every baby, if diagnosed with BPD, we're going to screen them for chronic pulmonary hypertension if they are on oxygen at around 36 weeks. We also are looking at babies that are considered to be high risk and screening them early at 32 weeks, just to make the intervention a little bit earlier and trying to reduce those complications. And we picked up so many cases even with other comorbidities like pulmonary vein stenosis. And that's also challenging if we're going to rely on echo as well, because we have to understand our limitations. Echo is going to pick up around, the sensitivity for echo for pulmonary hypertension is around 80%. If you're going to rely on, conventional parameters of pulmonary hypertension, like the presence of tricuspid regurg, the septums being deviated, and so on and so forth, you're going to miss around 30 to 40% of those babies. That's why in our policy we included so many parameters that are also looking at very subtle changes in the heart that can indicate the presence of pulmonary hypertension. But again, it's still quite important and useful and reproducible. So there is a lot of inter-reader agreement in diagnosing pulmonary hypertension between cardiologists. So if cardiologist A looks at it and the cardiologist B looks at it, we're going to have the same findings almost between them all. The main stream, or the first line of therapy for babies with BPD-associated pulmonary hypertension is going to be spironolactone hydrochlorothiazide. It is not sildenafil for those babies. It's not nitric oxide for sure. Sildenafil can be considered the second line. But there is something very specific about spironolactone. It blocks the hypertrophy of the RV and reduces the remodeling, and also puts the baby in a low preload state, because the phenotype here is mostly of the post-capillary. You want to decrease the preload to decrease the pulmonary venous congestion. Also by Faith Zhu and Amish Jane in Mount Sinai, they did a quality improvement where they started them on spironolactone or hydrochlorothiazide, those babies with diagnosed BPD-associated pulmonary hypertension, and they saw the markers of pulmonary hypertension getting better with time. So they established that using those medications actually alter the course of the disease. Another entity that I think is important, and we need to shed some light on it, it's gaining, there's a lot of interest about it right now, and maybe it's gaining more importance because we're recognizing it more. Is pulmonary vein stenosis. Once you screen more babies with BPD-associated pulmonary hypertension, you will find some of them to have it. For example, the countries with highest diagnosis of pulmonary vein stenosis is Spain. It's not because Spain is different than any other population, but they're actually screening for it more. They are doing CT angios for many babies with severe pulmonary hypertension after discharge, and they're picking up even subtle cases of pulmonary vein stenosis. The theory behind it, that there is a lot of pressure on the pulmonary veins, and that causes pressure and proliferation of the vessels, which makes it narrow and narrow and narrow until it is becoming completely atretic.
Five minutes, Dr. Talal.
Okay. Why is this important? Because also, if you look at the survival of those babies that are diagnosed with pulmonary vein stenosis, it goes down significantly. If you have one, the mortality is very high, but if you have 2 or 3, you're going to have the mortality even higher. So it's a very grim diagnosis. I want to share a case here that I'm sure it's going to be very surprising to some of us only. So we had a case here of a 1-hour-old, 37 weeks IOGR with RDS. The saturation was low, around 77. The preductal, the postductal was 65. The blood pressure was low, and the FiO2 was high. The lactate was high as well. And by looking at the echo, if you can play it, guys. By looking at the echo, we can see that the LV and RV are both dysfunctional. Can you play it, please? Yeah. The one underneath it as well. And we see that the PDA, which is the one on the right here, is complete right to left, indicating suprasystemic pulmonary hypertension. All of the parameters actually showed us that there is biventricular dysfunction. The TAPC is low, the global longitudinal strain is also low. So the phenotype here we had is severe LV and RV dysfunction, which is a post-capillary phenotype. So what we did here, so I want to see how many hands here if you would start nitric oxide on this baby. Would you start a baby here on nitric oxide or not? I see a lot of people saying no. You start. Okay, good. So we have people that are with and against. So we actually did not start pulmonary vasodilators here. We started epinephrine here, a low dose epinephrine, just because there is LV dysfunction, and LV dysfunction is considered to be one of the contraindications to start nitric oxide, because it will increase the pulmonary blood flow to the lungs, and therefore you're going to put all of that fluid back to the left ventricle, and it's already dysfunctional. And you want to keep the systemic circulation on by maintaining the right to left shunting, because it's providing the systemic circulation. So 12 hours later, the saturation got better a little bit. The pressures also got a little bit better. Lactate came down, and the FiO2 now is around 75%. Team, if we can play it, please. So what we can see here from the one on the bottom right side is that PDA now is becoming bidirectional. It's no longer right to left, and the function seems a little bit better, but you can see that the RV and the LV is still dilated, indicating that the pressures are still high. Also, the parameters showing us that there is very minor improvement in the TAPC and the global longitudinal strain, and the shunt is bidirectional, but it's mostly right to left. So we have improving LV. The RV is still dysfunctional with our TAPC. So we continued on epinephrine, and because of the blood pressure is now getting better, milrinone was started, and we know that it's going to improve your contractility and also decrease the pulmonary vascular resistance. So now on day 2, the blood pressure is better, the lactate is dropping, the saturation is around 90, FiO2 is a little bit better, but the functions is getting better as well. The PDA is still right to left, but we noted that the blood pressure, especially the diastolic, is getting lower and lower. This indicates that we might have a low preload state, so we wanted to improve it by starting vasopressin. The blood pressure also got better. At that time, after 3 days, FiO2 getting better, we shifted the baby to conventional ventilation. The TAPC is better, the strain is better, the PDA is also right to left. And at that time only started on nitric oxide. And what we can see here, that the shunt is becoming left to right. 1 minute, so I'll try to finish. You have to give me some time because of the technical problems. Okay. So what you can note here, that we waited for a pretty good time to start nitric oxide, and that can be surprising for a lot. Have you really waited for 2 days to start nitric? But I want to share also another important case that I think we lost this baby because of our failure. So this was a 30-week old baby, day 8 of life. This baby had a picture of sepsis. The baby was a happy baby on CPAP, then intubated, and then on high frequency, high FiO2. There was a pre-post ductal difference, so the staff at that time thought, this is classic pulmonary hypertension, let's just start nitric oxide here. Baby was hypotensive and started on dopamine, went up to 20, and now I've been telling you for the past 2 years, maybe we haven't been using dopamine at all. And started on dobutamine and then vasopressin and pretty high doses. And if you can look at those echoes, if team, if you can play it, please, you can see that there's severe RV and LV dysfunction. So what have we done to this baby by giving them those medications that while the baby is having a dysfunctional heart? Let's go back to our formula: pulmonary pressures and pulmonary vascular resistance and pulmonary venous pressure. So we gave him dopamine, and we know dopamine, although increases the systemic vascular resistance, increases the pulmonary vascular resistance as well. So we made more strain on the right ventricle, and we gave this baby INO, and this will increase the pulmonary blood flow, but we already have a failing LV. Vasopressin will increase the LV, will increase systemic vascular resistance, but really lacks any LV function. So we are increasing the afterload to the LV without supporting it. So this cocktail, unfortunately, although sounds nice from the beginning, it did not benefit this baby and actually tipped this baby over, and the baby did not make it. So I don't think we have enough for more scenarios, but this scenario was just talking about a baby that is typically responsive for nitric oxide. What do you really see on the echo? And the summary of this one is that you need a good LV and RV function before considering starting nitric oxide, not to make things worse. And similar case here where the baby was not started on nitric. And the final case is a case of pulmonary venous stenosis that was noted on just screening echo. And if we haven't really screened it, we have not picked it up. Another thing as well is for the neonatologists that they maybe don't have hemodynamics or TNE at their center. Try to come up with a policy for screening of pulmonary hypertension. And you specifically need to ask your cardiologist, how is your pulmonary veins at the time of diagnosis? Because if they usually looked at the echo at the first time, they will not look at the pulmonary veins again unless you ask them. So that's the message for today. So just to summarize, preterm infants with severe hypoxic respiratory failure and pulmonary hypertension demonstrate a response. Later than that is unlikely to demonstrate a response. And it's very important to have a standardized screening protocol for BBD-associated pulmonary hypertension. Thank you very much.
Thank you, Dr. Talal, for this informative lecture, and our apology for the technical issues. Our next speaker, or let's say our next lecture, will be a topic of wide debate and controversy, and it's very important in our neonatal medicine. Will be presented by Dr. Samir Al-Abdi. He's a neonatology consultant and head of the department in Lahsa Private Hospital. Dr. Al-Abdi has over 25 years experience in neonatology, and he has plenty of significant researches in IVH and neonatal hyperbilirubinemia that's related to the G6PD deficiency particularly. And he authored lots of peer-reviewed journals, national and international, national and international journals, I mean peer-reviewed articles. Welcome, Dr. Samir Al-Abdi. تفضل.
I'm really excited to be here today to present in this conference, and especially meeting all the friends and knowing somebody that we know from social media. I have some closure here, so don't يعني. Okay. My talk today will not be that heavy, and I don't promise that I will solve the challenge that raised by Dr. Ruqayya, but maybe I will give you some tools that you can solve it at your unit. My goal talk today is panacea. Then I will give you some definition, correct of my wrong misconception, and try to go through briefly of factors that if we change it, we might increase the survival of extreme premature babies. In the literature, they define the viability is the gestational age where the survival will be 50%, regardless of the long-term outcome or impairment. And any age that the survival is almost zero, they call it the cutoff. So for example, if your survival rate at your hospital around 25 weeks is 50%, then this is the viable gestational age. Whereas if the 23 weeks is zero, then your pre-viable age will be from 23 to 25. Any abortion during the pre-viable period is ethically considered abortion, induced abortion. That's why in the most of the literature, in neonatology literature, the pre-viable age between 22 weeks to 24 plus 6 days. And most of the less than 22 weeks is considered pre-viable. Across the globe, there is many different definitions of viability as well as the stillbirth. It ranges from 22 weeks in 20 weeks in USA and to 28 weeks in WHO. And the WHO choose 28 because it is for all the globe. So they take consideration the low income and high income. Still, some countries use the cutoff of the birth weight instead of gestational age around 500. But you can, from this slide, is not one definition, is multi-definition, and every institute, every country, they have their own criteria. I'm sure every neonatologist know this debate. This is from Islamic point of view, how they define the viability. I think every neonatologist in Saudi Arabia, and they know the debate that Quran says that the pregnancy and the breastfeeding is 30 months, whereas in other ayahs says it is 24 months, 2 years. So if you take this out of that, then you end up with 6 months. And I think Islamic scholars nowadays, they believe that least pregnancies is 6 months. And this is easy to understand, but it is tricky to apply it. The same thing, the Council of Senior in our Saudi Arabia, they also, their fatwa, their decision is the same, 6 months. So 6 months of pregnancy and above, then we should state below 6 months of pregnancy, then depend on the opinion of 2 physicians. And this is published or announced in 2008. 2009, our great teacher and Abu Yazid, Dr. Sahal Ayan, Allah يمسيه بالخير ويعطيه الصحة والعافية, he is the first one in Saudi Arabia translate in English, in medical literature, what the Islamic counselor says into medical literature. And he said the 6 months that is in the fatwa is equals to 177 days. And this will equal to 25 weeks and 2 days according to our gestational age. And I agree with him, and I published a paper with him, quoted that this 6 months is equal to 25 weeks plus 2 days. Is that true or not? You will see now in the next slide.
سؤال جيد. كثير من الأطباء يحسبون مدة الحمل من أول يوم من آخر حيضة، من آخر دورة الشرعية للمرأة قبل الحمل. هكذا يحسبونها، أول يوم من آخر حيضة للمرأة قبل الحمل. وهذا الحساب غير مقبول من الناحية الفقهية الشرعية، غير مقبول. لأن المرأة لم تحمل بعد، كيف يحسب من أول يوم من آخر حيضة؟ وإنما حساب الحمل الصحيح من حين التقاء الحيوان المنوي بالبويضة.
جميل.
هنا تبدأ المدة. الحساب الآلي والحساب اليدوي من أول يوم من آخر حيضة هذا غير مقبول من الناحية الشرعية. لكن الحسبة الصحيحة للحمل أن تكون من التقاء الحيوان المنوي بالبويضة فيحسب. ويسألون عن عمر الحمل، يبدأ بحسبة ذلك من أول يوم من آخر حيضة. هذا غير مقبول من الناحية الشرعية. حساب الحمل الصحيح من التقاء الحيوان المنوي بالبويضة. وينبغي الأطباء المسلمين يعني أن يكون عندهم وعي بهذا، يعني بهذا المعنى الشرعي أقصد، بهذا المعنى الشرعي، لأنهم يأخذون هذه الأشياء عن غيرهم من الأطباء في بلاد الغرب وغيرها. لكن الطبيب المسلم والطبيبة المسلمة ينبغي أن يعرف هذه المسألة، وأن يعرف أن الحمل إنما يحسب من حين التقاء الحيوان المنوي بالبويضة.
So I totally agree with Dr. Al-Khatlan. So what we did, we applied our knowledge on the Islamic knowledge and what Allah says. So we consider the way we are calculating the gestational age is what the Islamic scholar want. We don't ask them, what do you mean by 6 months? And I think this was our mistake. We should ask them, what do you mean by 6 months? And we know in the medical literature, based on the date of conception, we have 3 terminology. We have gestational age, which is what we use in daily practice, which is based on LMB, which is from Islamic point of view, this is incorrect. And really it's incorrect because we count the pregnancy before the pregnancy occurs. And we have sonographic age, which is by obstetrician, and we have the conceptual age. And I think Islamic people, and I truly agree with them, when we are talking about the fatwa, we should think about conceptual age in the middle of the cycle, where exactly like IVF. Now, if you do that in timeline, then it will be very clear. The 6 months of shuyukh or scholar or Islam, it's equal to 27 weeks plus 2 days. Is not 25. So if you want to apply the fatwa, then the cutoff is 27 of our calculated gestation age. And this is make more sense. How come 25 weeks in that days will survive? 27, it makes it more blittable, biological blittable. Even maybe the calculated pregnancy is different from us. That means 27, that days they will be 29 or 30. So this is one of my misconceptions that I did in the past. And I think the fatwa mean 25, it's not 25, it's 27 plus 2 days. Now in Saudi Arabia, Ministry of Health and the Saudi Neonatology Society, they use 24 weeks as a cutoff or more than 500. In USA, they published their algorithm or their recommendation for antenatal care. And I think there is 2 landmarks in this table. 23 weeks, then where we consider the antenatal care, and the 25 weeks where they recommended antenatal care. So you can sense from this table that at 23 weeks is toward the viability. I did this slide to show you the outcome across the globe. And we know as a neonatologist, the best country that have excellent outcome in 22 or 23 is Japan. And still Japan, whereas the other countries still they are behind. But the other thing in this slide is at 23 weeks, the survival, except Japan, the survival is 50%. That means if we apply the definition that I said in the first slide, 50% of survival, then 23 weeks maybe or probably the cutoff of viability. Now, if you want to use the gestational birth weight, like in some country in USA, in Europe, or in Saudi and SNS, some people use 500. طبعا اللي play card he knows what mean 500 في السلايد هذه. 400 or 350. 350 is Japan. If you remember in the last edition, not this one, the previous one of American Academy of Pediatrics, they use a cutoff of 400. In the new edition is not anymore there. But my personal belief is 400 may be reasonable. Why? Because if you start to save small babies, then the outcome of 500 will be improved. Now, there is many factors, if modifiable, that will improve the survival of extreme mature baby and decrease the complication. I only quoted 10. I bought 1 to 4. This is the debatable or hard to apply. And from 5 to 10, I think most of the neonatologists agree upon, and I think we have no problem with that. Now, let me start with the debatable one. I will start with the panacea. Panacea in the dictionary in English dictionary means a medication or remedy that will one fit all, that will treat everybody, treat every disease. That is the meaning of panacea. What I mean here in panacea today is a medication that I will disclose the name in the next slide, and I keep it now secret just to increase your ambition. This medication, it is available in many drug formulary. It is available IV, oral, even intramuscular, nebulization, skin patch, lozenges, cream. In Saudi Arabia, we have it only as oral syrup. We don't have the other formulary. Now, this medication is an old plant. Plant was in India, then extracted to another medication, and the panacea is the active ingredient of that medication. So what that medication will do, if we give it to a pregnant lady, it will act like the hydrocortisone. It will enhance the surfactant, enhance the lung maturation, enhance the baby maturation, although will be in different mechanism. For example, this medication will increase the lamellar body density and number, which is the storage of surfactant. Now, there is a few studies and randomized control trial done on this medication, although it's small, although it's old, but not older than the studies of antenatal corticosteroid. The Cochrane review, when they did their review in 2014, as usual, they stand in the fence and they said, we cannot recommend and we cannot review it or be against this medication. Now, if this medication, if you give it to a premature baby after delivery, it will act like surfactant in meaning of treating the RDS. So it will increase and enhance the lung function. It improve the penetration of antibiotic to the lung. And it is actually antibacterial because it acts against the biofilm that is produced by coagulase negative and Staph aureus and Pseudomonas. It's also used in meconium. And all this is proved by small studies that done some part of the world. Now, if you give it to patient with patent ductus arteriosus, the patent also will be closed. And the beautiful of this medication, the mechanism of action is different from the 3 medications that we use currently in our practice, namely indomethacin, ibuprofen, paracetamol. All these 3 medications that currently are used to close the duct act through cyclooxygenase inhibition. This medication, it acts against nitric oxide, and this is maybe will not make Talal happy. So this medication may counteract nitric oxide. And why it's important? Because we know the mechanism of patent dactylorrheosis in the first 2 weeks is prostaglandin dependent. After 2 weeks, it's nitric oxide dependent. And this medication might be is good if you want to close the duct after 2 weeks. Now, this medication also causes vasoconstriction and antioxidant and anti-inflammatory. So they found it might prevent IVH. I have said it is antioxidant. I have said it is anti-inflammatory. In Japan, it is until currently is used as a prevention for BPD. Our BPD rate in Saudi Arabia and Gulf for alhamdulillah is very low comparing to North America or Europe. In extreme premature baby, the incidence of PPD is up to 50-60%, and some unit 80. In Saudi Arabia, is not more 20%. So usually we don't much weight on PPD prevention or treatment because we need a number to treat will be very high in Saudi Arabia. Anyway, this medication also has some limitation. It is not approved by American FDA. That's why it's not available in USA and not available in Canada. That's why people coming in from these countries, they didn't agree to use this medication, and their medication will be out of their market. But I think in coming 2 years, this medication will be available in America and United States. Why I'm saying that? because this medication has been shown in retrospective studies and some cohort studies. It's beneficial for Alzheimer's disease, for Parkinsonism and particular Parkinsonism, and is very effective for Gaucher disease. And we know Gaucher disease is one of the disease that we have no medication. And nowadays there is big trials in North America and Europe trying to see as if it is really beneficial in this disease. Once it will be shown beneficial, then it will be available in the market in North America. Then if it's available in the market, then neonatologists can use it as off-label. Now, okay. Now I will disclose the medication. The medication is Ambraxol. And I'm sure all of you, all of us and all of your audience have used this medication, but by different brand name, most commonly Mycosulfone. And the Ambraxol is the active ingredient of biosulfone. Pediatric critical care, they use it a lot for secretions, as a mucolytic, as a cough. But all the data I have said and more, we have published it recently in a review article if somebody wants to read more. Now, my other debate thing is, what is the most microorganism will be cultured from a pregnant lady going in a premature baby? All the textbook, all the neonatologists, they have one statement. The most organism is Uroplasma species. It's not GPS, it's not E. coli, it's not Klebsiella. And believe me, despite we know it is the most common organism that could be cultured from amniotic fluid, we don't treat them. We use ampicillin and amoxicillin as an empirical treatment, and if you ask us why ampicillin, because of Listeria monocytogenes, and I don't see any case in my life, and I'm sure Dr. Fouadi doesn't see any case in that. And where the organism is very common, we don't touch them. We don't even come close. And the treatment for this organism is azithromycin or macrolide. And we know that this organism can cause many diseases. It's not only RDS, it's not only IVH. Okay. Now, I'm sure everybody come this across scenario. You start with a premature baby that his lung was okay, moderately sick, with moderate sitting, but it quickly gets sick. And day 10, we have this X-ray. We label this X-ray in the clinical, in the clinical round as early PPD. It's not early PPD. This guy is carrying uroplasma reticulum. If the baby has negative, then they have the progressive disease, the normal progressive disease. Now the problem why we don't use azithromycin, because we are targeting azithromycin to prevent uroplasma, to reduce the PPD, and this is a very debatable. And the last study published last year, they found there is no benefit from azithromycin if you want to target PPD. If you target something else, yes, it's beneficial. But if you are aiming to reduce PPD, then maybe azithromycin will be disappointed. Delayed cortical clamping. We know now standard of care, delayed cortical clamping. But why in the premature baby is difficult? In the best setting where the best randomized trial, best RCT is done in the world, still the rate is very suboptimal, is up to 50% the most, because we need to set the baby and we need to separate the mother. So how to solve this problem? It can be solved by intact cord station. Keep the cord intact and do station. And how we can do this? We can do that by use Concord or LifeStar or any trolley that carries all what you need for CPR and just bring it close to the mother. And there is going to study on this thing, and retrospective studies prove that using the intact cord station increase the rate of delayed cortical clamping. And if you can delay cortical clamping, then you are going to increase the survival of the extreme premature baby and to prevent the IVH. The last thing is debatable in extreme premature baby is the mode of delivery. Shall we deliver the baby at 23, 24 by cesarean section or vaginal delivery? It's debatable, but once you reach 25, cesarean section is the standard for the care for fetal distress or indication. The more debatable thing nowadays is not only cesarean section, in cold birth. What mean of in cold birth? That the baby will deliver with a sac. This can happen in nature, but this is very rare and extremely rare. Now in Montreal, they start to do it vaginally. In Japan, where I said the survival is the best, they do it even cesarean section. So maybe it's a good option if you want to change the practice or to improve the practice to think of in-call. I think I finished here. Just I summarized my take-home messages. If you want to use the fatwa, then the cutoff age is 27 plus 2 days, not 25. My belief is 23. If you want to use the birth weight, the Ministry of Health and SNS, they quoted 500. I think it's 400. Now, think about Mbraxol. If you don't believe what I said, if you read the article that we published and still you are doubting the evidence, so think of it as a research way. I think it is an ethical issue if you know something is going to work and you didn't give it to the patient. Now, azithromycin. I think this is good chance to give azithromycin. You are going to treat organism that you cannot culture routinely because uroplasma reticulum is not cultured by usual culture, it needs PCR. So please think of it as azithromycin. Try to delay the cord clumping. Use something is useful, like bringing that trolley to the mother. I know maybe social issues, but sometimes we need to do it. Then maybe you need to open the discussion with your obstetrician about in-call birth. I will stop here. Thank you.
Thank you, Dr. Samir, for the rich and informative lecture. Our next speaker is Dr. مريم عايد. She will present a virtual lecture, unfortunately. She is not able to come. مريم عايد is a neonatal, perinatal and neonatal neurocritical consultant at Maternity Hospital in Al-Kuwait. She is also the president of Kuwait Neonatal Association. Dr. Aid graduated with honor degree from Al-Kuwait University. She had her pediatric residency program and she is certified from Canadian and American board. Further, she finished her fellowship in neonatal perinatal medicine and neonatal neurocritical medicine in Canada. She had also postdoctoral master degree in clinical research from Harvard University. Welcome, Dr. مريم.
السلام عليكم. Thank you, دكتورة رقية, for the introduction. طبعا يشرفني أكون معاكم اليوم بالمحاضرة. I do have a mixed feeling. It's a pleasure to be and present here, but يعني يؤلمني إن ما أكون معاكم وأشوفكم وأشارككم حضوريا في هذا المؤتمر. الله يعطيكم العافية والسلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. I have nothing to disclose, and my objectives for today is to discuss through the neuromonitoring tools that we use in the neurocritical care, which are the near-infrared spectroscopy and the amplitude integrated EEG. We will identify situations where both NIRS and AAG monitoring will provide some important clues to the status of fragile neonate. Neurocritical care is a growing multidisciplinary service with a main goal to protect the neonatal brain. Implementation of neurocritical care guidelines and protocol has shown to improve the neurological outcome for the neonate, mainly by reducing the seizure burden, early seizure detection, and the success of treatment, lower progression of the seizures to status epilepticus, and therefore shorter hospital stay, and decrease the number of patient discharge on medications. And before we start through the neuromonitoring, I think we're all familiar with this graph. As a neonatologist, our daily intervention practice can affect an important organ, which is the brain, through the immature cerebral autoregulation in the neonatal brain. So the cerebral autoregulation is a mechanism by which the cerebral blood flow remains constant despite fluctuation in the cerebral perfusion pressure, which is the black line here. We call it the cerebral auto regulation or the plateau. excuse me. I'm not sure if you hear my voice well. Can you hear me well? Okay. So for the cerebral autoregulation, this is the black line here is the autoregulation plateau, which means that the cerebral blood flow remains constant despite changes in the cerebral perfusion pressure or the baby's blood pressure. And we do have the upper limit autoregulation and the lower limit autoregulation, where beyond these points, there will be the regulation will be passive. So if it's further increase in the cerebral perfusion pressure, the cerebral vasoreactivity the blood vessel will dilate and can lead to hyperemia or the risk of intracranial hemorrhage. If we have the lower limit of the autoregulation, then again, the autoregulation will be passive. So if a decrease in the cerebral perfusion pressure, the blood vessel will collapse and the risk of cerebral ischemia. An example of the cerebral vasodilatation that we have is hypercapnia, acidosis, lactic acidosis, and hypoglycemia. And you can see this in the red line here, that the autoregulation is shortening. And therefore, there is a highest risk of early autoregulation becoming passive and the risk of bleeding. On the other hand, if you have a cerebral vasoconstriction, like in case of hyperoxia, alkalosis, or hypocapnia, the line will be longer to enter to the vasoconstriction. Another important point we have to keep in mind is something called the critical closing pressure. And it's different than the lower limit of autoregulation. The critical closing pressure is the arterial blood pressure, which is below it that there is no more cerebral perfusion pressure. So the cerebral blood flow will completely stop. Unlike the lower limit of the autoregulation, once it hits the lower limit of autoregulation, then become passive and there is vasoconstriction. However, then critical closing pressure, once we reach it, the blood flow to the cerebral or the cerebral perfusion will completely stop. And it's mature and increase with increasing gestational age, with around 1.4 millimeter mercury by each gestational age. And usually at term equivalent is around 22 to 32 millimeter mercury. So at the cellular level, we know that the cerebral oxygen, it depends on the oxygen delivery, oxygen content, and the biochemistry that regulate the blood-brain barrier. At the tissue level, the cerebral blood flow is also regulated by the neuronal metabolism and activity. And we all know from the physiology that the perfusion pressure also has or the vascular resistance has an impact on the perfusion pressure. And the vascular resistance can be regulated by calcium nitric oxide. So how can we indirectly, non-invasively measure the cerebral perfusion pressure or the cerebral autoregulation? By one is the near-infrared spectroscopy, and second by the amplitude integrated EEG. So what's near-infrared spectroscopy? It's a continuous, real-time, non-invasive bedside monitoring that measures the regional tissue hemoglobin oxygen saturation. It's through that, it's a sensor that's applied to the forehead, and there is an infrared light that pass around 3 to 4 centimeters below the scalp, and then get absorbed and detected by a detector or a sensor. It measures the oxygen saturation. It reflects the venous return, or the collection of the oxygen saturation on the arterial, which is around 20%, capillary, which is around 5%, and 70% of the venous blood. Equipment that we need to measure the near-infrared spectroscopy, we need the sensor, different devices out there in the market that can measure the regional oxygen saturation. And commonly in the neonatal practice, 2 sites we usually use is the cerebral and the renal. Now the renal has more challenges, but it's actually is more dependent on the cardiac output. And we found that if we apply for the renal sensor, the monitoring through the regional oxygen saturation in the flank of the renal can detect earlier drop in the cardiac output before even the changes in the cerebral perfusion. The values is different values out there in the literature, but you can see here in the plot, the white is around 24 weeks, and as the color gets darker, the gestational age, 25, 26, and 27, up to 28 to 32 weeks in the dark gray. Immediately after birth, around 3 minutes, usually the reading is around 44% in the regional oxygen saturation, and increases gradually to around 75% at 7 minutes. And then it's reached its peak around 36 hours. Usually, if you look at the average here, if you, even if the first 24 hours or the 36 hours, the average reading of the regional oxygen saturation is around 55 to 85%, and this is what we've shown to be safe as a neuroprotection number, is anyway between 55 to 85. Now, any number below 45% has shown that it's associated with more cellular and neuronal injury. Now, advanced gestational age, or with advanced gestational age, as we said, that we start around anywhere from the average 75, but 55 to 85, and it did decrease at around 36 weeks gestation, and then back to around 55%. It's extremely important to keep in mind that when we interpret near-infrared spectroscopy, that we have to monitor the baby's baseline, and then any significant increase or decrease from the baseline around more than 20%, this may present a change in the status of the baby than relying only on one absolute number. We all know from the autoregulation that decreased cerebral oxygen saturation means there is something happening with whether decreased oxygen delivery or increased consumption. Anything, as we said, below 55, this is a red flag, and we have to find out why the baby had a dropping on his regional oxygen saturation. On the other hand, if we have increased regional oxygen saturation, meaning that there is too much oxygen delivery, or the brain basically is not consuming the oxygen that it's going to the neuronal cells. Anything more than 90% has to be evaluated. This is how to show that how the cerebral perfusion can be affected by the hypercapnia or increased CO2. So if you can see here on the gray line that there is a dropping in the regional oxygen saturation, the same time where we have, sorry, this is hypocapnia, not hypercapnia, where there is a dropping in the end-tidal CO2. So the end-tidal CO2 or hypocapnia can cause cerebral vasoconstriction, and simultaneously you have a dropping on the oxygen, regional oxygen saturation. Another example where you see the pressure passive brain perfusion, where you can see on the blue line, there is an increasing and decreasing with the regional oxygen saturation. At the same time, you have an increase and decrease on the arterial blood pressure, or the main blood pressure here. So this is extremely important to monitor, rather having the baby continuously monitoring his carbon dioxide. And a clue you can tell that the baby is overventilating by monitoring the regional oxygen saturation. And more so, and I think we learned from Dr. Talal's lecture that we don't really rely on one reading, rather than we collect the whole data together. So if you have a baby with hypotension, but he's really, especially in the first transitioning area where they have systemic vasodilatation, but they're actually not affected in terms of end organ perfusion. So you have low blood pressure, but the baby otherwise has normal urine output, no lactic acidosis, no tachycardia, normal cab refill, and normal reading of the regional cerebral oxygen saturation. So really doesn't, this patient doesn't require any intervention. On the other hand, the baby has normal blood pressure, however, has signs of low end organ flow, feeding intolerance, or low regional oxygen saturation. And then in this case, I should intervene even if the blood pressure reading is normal. So what's our approach to a low regional oxygen saturation? You can see the line here. It's all was ranging in around 45%. And then you did something and it's increased. So this is an example where we gave the baby backed RBC and it decreased. So if we have a decreased regional oxygen saturation, again, you think of decreased oxygen delivery or increased oxygen consumption. Decreased oxygen delivery, whether you have an anemia, hypoxia, hypotension, increased main airway pressure, and therefore you're decreasing your venous return, or hypocapnia. Or you have an increased oxygen consumption, like in fever, pain, or seizures. Increased regional oxygen saturation is the opposite. You have increased oxygen delivery, like hyperoxia, you're over-oxygenating your patient, hypertension, hypoglycemia, hypoglycemia, or hypercapnia. Or you have decreased oxygen consumption, and we often see it with the cases where there is a severe hypoxic ischemic encephalopathy, or sometimes with severe sedation, over-sedation. So the sorry?
5 minutes.
Okay, factors affecting the near-infrared spectroscopy sensor type. So please pay attention to the sensor type, because most of the studies have used adult type, and its adult types have a 10% lower reading than the neonatal type. So make sure you know what type of sensor you're using. Position, we often use, neonate have a small forehead. If you put it ideal, you have to put it to the right side or the left side, not avoid the midline, but sometimes it's really difficult to apply it to the slightly tilted to the right or the left. And they found even if you are fixed to one direction every time, with a minor changes, decimal millimeter, changes in the position, associated around 18% difference in the reading. So that's why it's important to take the average or the baseline, rather, one single point. Gestational age also affects the reading of the near-infrared. Head position, if it's hyperextending, lower or flexion. Gender, some evidence has shown that male have different reading in the near-infrared. Daily intervention, our suction, our blood gas analysis, or our invasive procedure that we're doing can affect skin pigmentation, and especially hyperbilirubinemia can lead to displacement of the hemoglobin and affect our reading. A quick example here, we have this patient, 28-weeker, day 14 of life, had near-infrared applied, and then he has normal vital signs. The range of his the regional oxygen saturation around 58%, and then started dropping, seeing the red arrow, and then becoming 49, and then the baby showed an acute collapse with heart rate 78 and bradycardia and hypoxia. So things that we usually have to do, not to wait until the baby really collapses. Rather, you should focus on why the baby has sudden decreasing in his baseline. Maybe it's as simple as it's dope, or there is a baby's becoming septic, and so forth. So in this scenario, this patient had an pneumothorax. So I'm talking fast because of the short time now. So now I'll go to the amplitude integrated EEG and the use. A quick overview of the EEG. It's a simple way or a modified way of the international 10 to 20 leads EEG, where they filter the frequency. Anything below 2 hertz, more than 15 hertz, they will be filtered, and then will be rectified. The negative will be positive, and then compressed in a 1 time scale, 6 centimeter in 1 or 2 hours, depends on your machine. There is limitation, however, on the AAG. We cannot detect all seizures. It's around, it depends where you apply the lead. It's around 40 to 70%, 70 on the cortical lead or the central lead, and then the frontal is around 30 or 40% you can detect seizure. Seizure of short, less than 30 seconds, or low amplitude, you may miss it. This is an example of the common used EEG or AAG, is the single channel, whether it's the frontal F or the central C or parietal P, or the 2 channels that we use, it's C3, C4, B3, and B4. Indications, any sick babies, you have to apply AAG, especially where you have encephalopathic or HIE seizure, grade 4 or more, grade 3 or more IVH, sick neonate, or anytime you're suspecting seizures. When you interpret, you have to look at 6 important things. Most importantly, look at the background to assess the degree of encephalopathy and if there is a seizure, so you can intervene. The background, we have 5 common patterns that we usually follow, and it depends on the lower margin and the upper margin to continuous normal voltage, discontinuous, burst suppression, low voltage, and flat tracing. So continuous normal voltage, if the lower margin is more than 5 and the upper margin is more than 10, and this is normal in all of the neonate. Discontinuous, the upper margin is more than 10, but the lower margin is less than 5. It's normal in premature babies, it's abnormal in full-term babies. Burst suppression, where you have both the lower and the upper margin, or the lower margin less than 5, and it's close to 0, 1 to 2, and then you have a burst more than 25. Status epilepticus, where you have a spike patterns, where there is a sudden increase in the lower margin, يعني sudden hiccups نسميها, أو with narrowing of the bandwidth. Flat tracing is flat trace, really, there is no variability, the lower and the upper margin both close to 0. Okay, seizure, this is an example of seizure where you have repetitive spikes that last more than 10 seconds. Sleep-wake cycling, it's extremely important for brain maturation, where it's about sinusoidal variation, where narrowing and widening of the bandwidth. Variation of the gestational age in sleep-wake cycling, it's increased with gestational age. This is by gestational age, how do you, the different background representing in the gestational age. Burst suppression is extremely important to assess, and some mode or machines in the AAG can actually measure the burst suppression for you, and it does help you to identify patients who are eligible for therapeutic hypothermia, especially if you have not clear picture of the criteria A. And as you know, the evolution of the B, which is the neurological exam, may not be very obvious at the first 1 or 2 or 3 hours of life. So you may rely on the AAG background and the presence of burst suppression to initiate hypothermia. This is discontinuous background. As I said, it's very common in a premature baby up to 35 weeks, and it decreases مع gestational age. Artifact, you have to keep in mind because it may mimic seizure and sometimes and can affect your interpretation. So lastly, this is an example of our neurocritical care unit where you have a baby with who had birth asphyxia with a basic CIS minus 19, applied EEG, near infrared spectroscopy. His first 6 hours showing burst suppression, and his near infrared spectroscopy 90. So this is all matching and going with a severe encephalopathy. So my take-home messages is that continuous neuromonitoring the neonatal intensive care unit allows for bedside assessment of brain oxygenation and perfusion, as well as cerebral function and seizure identification. Near-infrared spectroscopy reflect the balance of oxygen delivery and consumption, and AAG allows continuous bedside evaluation for cerebral background activity and help you to identify seizure. And with that, I end my presentation, and I thank you.
Thank you, Dr. مريم, for this informative lecture. And now the stage is open for discussion. Mr. Speakers, please. Dr. Talal and Dr. Samir, and Dr. مريم with us. Questions for the speakers?
Ayman al-Riyadi, thank you very much for very interesting topics. Actually, I have a question for Dr. Al-Abdi. If such medication is around for some time and there is an observed positive impact, why we are not seeing an RCTs for these medications? I know it's not probably applicable for the North American or Europe, but why elsewhere? And why not in here or elsewhere? This is one question. And second question also for Dr. مريم is, we have seen a lot of technology evolutions regarding specifically for the monitoring, but what would be the best to go for the multimodalities? Because this is something we have seen in neonatal ICU, adult ICU, pediatric ICU. There is certain accelerations in the technology, but do we have a clear benefit in the outcome, or at least a benefit even mechanistically for improved outcome? Thank you very much.
Shukran, Dr. Ayman. It's really excellent, brilliant question that I don't find until now the different answer, but I will tell you what I know so far. Ambrexol is not linked to any one of the big pharmaceutical company. So there is the company that deal is cheap company and they cannot support research. And most of the randomized control trial done before was in China and in Europe. Last month we tried to contact our old colleague in Toronto, and they expressed they're willing to conduct such something, but it was the pharmaceutical company. They are not that, rich company that can support. And as I said in the presentation, maybe if the ongoing on now trial prove that this medication is good for Parkinson's disease or etc., maybe the other funding agent maybe will be supportive. But really, I thank you for this question, and I hope we will see it going on or have randomized control trial in the future.
شكرا. دكتورة مريم, your part.
Thank you, Doctor, for the question. Are they important, the near-infrared and the AAG important, or they can add value to our current practice? The answer is yes, absolutely. It does help for the monitoring and the intervention. So it's an extra aid for the neonatologists and intensivists to help in the decision-making for any intervention they should do. And in particular, the amplitude integrated AEG. It helps for, as I said, in the background to identify patient for eligible for the therapeutic hypothermia and for the seizures. It does decrease the seizure burden, and the prediction of long-term outcome, it depends on the background and the normalization of the background by 72 hours and then 7 days. The near-infrared spectroscopy, it did not show any impact on the long-term outcome on the large recent randomized trial that published in the New England Journal. But there are some evidence from prospective studies that the near-infrared spectroscopy it can, the intervention using the near-infrared spectroscopy can have an impact on the long-term outcome, but it does affect our short-term outcome mainly by the intervention. So if you have a lower reading or higher reading, that will guide us to do further intervention like blood pressure monitoring. As the example I used, if you have a baby who is hypotensive, however, he has no impact on the cerebral perfusion pressure and reading is normal, so maybe this patient does not require any intervention. On the other hand, he has normal reading, but the near-infrared spectroscopy is low, so I should treat. Anemia, it's another example that we face in the neonatal department. Sometimes the baby had low hemoglobin level, and we go with the conservative approach, but we see that the baby's near-infrared spectroscopy is not optimal or it's low. Therefore, I should optimize his hemoglobin oxygen carrying capacity by giving the blood transfusion. So I think they are important and useful tools. You have to understand them first. You have to have a proper written guidelines and train people how to interpret, because the last thing you need an advanced technology, and you incorrectly act on these modalities.
Thank you, Dr. مريم. One more question. خلاص. Any question? Okay. Last question.
Dr. طلال, we have seen in practice, at least in small babies or some pediatric patients, that there's a variable response to nitric oxide. Variable response to nitric oxide. So do you think this is because of appropriate versus inappropriate applications or patient selection, or do we have other factors including in this, for example, the pharmacogenetics, how the interaction between the medications and the patients?
Thank you for the question. I don't think I have a clear, straight answer for this, but from a neonatal population, it depends on the physiology that we're dealing with. And if it's primarily due to high PVR, the phenotype is very close to like pulmonary hypoplasia and RDS, yet likely to be responsive. But I think from a clinical point of view, sometimes we start babies on nitric oxide and we just leave them on it for a long time. And they really do not show any clinical response. But on a echo point of view, we do see some subtle signs of actual deterioration. And we see this commonly with babies with diaphragmatic hernia because they are born with a degree of LV hypoplasia. So I think from a clinical point of view, if we start it and we don't see a clinical response, I think it's better to wean it off quickly before we deplete the endogenous nitric oxide and we cause more problems on the long term.
Thank you so much. We're done with our session, and we'll go for the next session. No break for now. Hematology will be presented by Dr. Hussein.
Thank you for these comprehensive and informative lectures from our speaker. Neonatology is always an area of interest as well as frequently and quickly updated. Now, before going to the lunch break, hematologist will supply us by 3 interesting topics. Please join me in welcoming our moderator, د.سامي البطاط, consultant pediatric hematology and oncology at Maternity and Children Hospital in الأحساء.
Assalamu alaikum, يعطيكم العافية. We are a little bit late, but we'll come to one of the lovely topics everybody like blood. So it's my pleasure today to introduce the first speaker, Boroféسور.أحمد طراوه. He's a professor in pediatric and pediatric hematology oncology in Hart University in London, and also he's working in medical city, King Salman Medical City in Medina Munawwara. طراوه is well known in pediatrics, hematology oncology. He's senior 1. He is national and international speakers, and he has a lot of publications. Dr. طراوه most welcome. In his topic, vulnerable disease, prolonged and excessive bleeding is a life-saving or life-threatening. Welcome, Dr. طراوه.
Thank you, Sami. Though I have shown you the stairs in front. Thank you, everybody. Thank you for the organizers for this invitation. While they are correcting this issue, where really I cannot read it very well, I want to express I do like the guy there, the beauty guy who is handling the cameras, and he's doing very great job, really. Well, I don't know what's happening, but vulnerable brand disease is a disease which is really very, very common. I'm coming to the epidemiology, but okay. So let me start with a patient I took care a while ago, and She is a 3-year-old girl. She has von Willebrand disease type 3. And she presented to emergency room with her hemoglobin of 3, and she had GI bleeding, started with melena, afterward tend to be fresh blood. Has been admitted to BICU and started on von Willebrand factor concentrate and giving back to RBCs. And our friend from the GI, they have shown through the endoscopy that she has angiodysplasia. Though she were continuing on the hair medication, but bleeding didn't stop. GI, they tried to do some GI intervention for this patient, but again, her bleeding didn't stop till we did ask our friend from the surgical bar to do resection for that bleeder. And that time, the bleeding has been stopped, and she spent 2 weeks in the hospital for the to stop her bleeding. Unfortunately, during the COVID era, she caught COVID and she died due to the pulmonary and respiratory arrest. Von Willebrand disease has been described by somebody, his name, Eric von Willebrand, and he described a girl, young girl with bleeding, and the first time, and at that time he didn't know what was that, and he called it hereditary pseudohemophilia. As the description was not. This is 100 years ago, and he could describe. Sorry, this is not working. Okay. So this is the family pedigree for that family, and this is the small island in the north of Europe described for the Glasman, and this is one of the meetings for von Willebrand disease held at the same home where the first patient described. Over years, over 100 years, we kept knowing more and more about von Willebrand disease, though over the last maybe 30 years, we are not progressing that much in producing more molecule for the treatment as compared to the hemophilia, but still we are progressing in the von Willebrand disease. It has been reported everywhere with variable type of the rate of the von Willebrand disease. In most instances, it is 1% of the community. And this is the WFH report for the all bleeding disorder. One of them is the von Willebrand disease. The interesting thing in this paragraph that look to the yellow bar where it is increasing. So we are describing von Willebrand and reporting von Willebrand more and more, and we keep diagnosing von Willebrand more and more. Though this number of von Willebrand worldwide, which is 100,000, it does not represent the von Willebrand disease. Let me give you this example from Saudi and Iran, where on a population-based study, we have reported 1,500 per 100,000, while we reported to WFH only 1.6. So we have a problem in reporting in Saudi Arabia. The reverse in Iran, where the base population was 1.8, but they have reported almost 2,000 cases. So still we do not know exactly how many von Willebrand we do have. We have, this is the Middle East report for the von Willebrand disease, and this is Dr. Awaida, whom he lead a project in Saudi Arabia about the rate of the von Willebrand among Saudis. And we came out that the von Willebrand is 3.9% among this special population. The one down, this is what we have done in Medina, and we have shown that most of the von Willebrand disease in Medina, where 60% of them, they were type 1, but look into type 3, it is 10% of the von Willebrand, which is high rate. To the knowledge of mine, in eastern side of Saudi Arabia, again, type 3 is high among those patients. And on the left side of yours, of mine, and maybe yours right side, this is the genetic characterization in Saudi Arabia. Type 1 is the most prevalent type, which is the milder type, where the von Willebrand is reduced, which is represent almost 60 to 80%, while type 3, which is 5%, 5 to 10%, it is the severe form of von Willebrand disease, while type 2, it is dysfunctional type, which is divided again into 2A, 2B, 2N, 2M. I cannot go over those details in 20 minutes. And the frequency of severe type 3, as I said earlier, in the Middle East is high. This is a publication coming from Israel where they've described the von Willebrand disease among Arab nations. They are living there where it was really high enough. Our friend from Iran, again, they have reported type 3 as high as that. In Medina, we have reported 10% of that. Very quickly about what is the rule of von Willebrand disease to control the bleeder. The von Willebrand disease, the one I read down, simply, it's a ligand. It attaches from one side to the collagen and from the other side to the platelets whenever you have an injury. So this is the primary coagulation where this is the adhesion happening. When you don't have or non-functioning von Willebrand, this process will never happen. When we talk about the types of the von Willebrand molecule, what is type 2B, what is type 2M, and so on, each part of the von Willebrand molecule has something to do, and any deficiency in there, it will lead to some sort of von Willebrand disease. This is the genetics about the domains of the molecule, von Willebrand molecule, and the mutation has been reported all over. We know the von Willebrand type 1 is autosomal in most of the cases. It can be an autosomal recessive, while type 3 is an autosomal recessive, alhamdulillah. And this is the other type of von Willebrand. I'll not go over this detail. Usually the von Willebrand disease present with mucocutaneous type of bleeding like bruises, epistaxis, gum bleeding, and very rarely that they will go for more serious bleeding, GI bleeding, like the patient I have presented, sinus bleeding, and hemarthrosis. How we diagnose and manage those patients with von Willebrand? There is so plenty of the guidelines coming out from everywhere in the world. Like every year there is somebody publishing a guideline for the von Willebrand, and this is some of them. And the first publication we have, our guideline we have made in Saudi Arabia, that was in 2012. And currently, it is not separate guideline, but it is chapter 7 of the hemophilia guideline in Saudi Arabia. I believe that it has not been published to public, and it is kept secret in Ministry of Health. I don't know for what. The ASH, ISTH, NHF, and WFH guideline, which is combined guideline, which is, I think, the perfect one to date. It has been published in 2021. And that showed a lot of argument we had about von Willebrand, how to diagnose. And believe me, when you come to the hematologist and you have a patient with von Willebrand disease, it's a simple disease. Why you cannot diagnose something as such? We keep quarreling about the von Willebrand disease diagnosis. First of all, a long time ago, this is a bleeding score that you ask the patient some question about his previous surgery, menstruation for the ladies, bruises, type of bleeding, blah, 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 and you come out with a score. And with that score, previously, we depend on this score to rule out a bleeding disorder. And the history, it is very important in any type of bleeding disorders. When we come out to the lab side, let us start with the initial test. We do CBC and platelet count. So the type 2B in von Willebrand disease, they will come with thrombocytopenia. And in CBC, you may find iron deficiency anemia due to frequent bleeding. BTT usually normal, thrombin time is normal, and platelet function analyzer, BFA 100 and BFA 200, will be prolonged, and this is important, what we call it closure time. So this is very important as a primary diagnosis for von Willebrand disease. In some cases, it will be normal. Now we will go for the specific type of test in von Willebrand disease. Simple one, the von Willebrand antigen. How much of von Willebrand do you have? Now, in type 3, it will be very simple that it will be deficient or there is very little, so you can diagnose type 3 among those patients. In type 1, you need to do it once, thrice, 4 times to reach a diagnosis for the von Willebrand disease, as it is affected by some other factor. I'll come to it. Then you will go for resuscitating cofactor SA, which is functional type, and you need to do the ratio between the antigen and function type, which is, tell you the truth, it is very difficult for the lab to do something as such and to give it to you so accurate. And this is the list of the specific tests where many of the hospitals, they don't have it, and it should be in research labs. This is how to measure the multimer, the big part of the von Willebrand molecule. And this is important when we come to the functional type of von Willebrand disease. And simply, you go for genetic testing. Nowadays, it costs you 1,600 Saudi riyals. Maybe it is perfect. When we go back to the guideline, they found out that when you depend on the bleeding score, which I did talk to you about in a moment, and unfortunately, in many cases, we do miss if depend. Many cases, they are von Willebrand disease or whatever, the bleeding disorder, but actually, when you go for bleeding score, they are normal and the reverse. So we don't need to depend on it that much. It may guide you, but you don't diagnose through that one. Now, there is some sort of new test coming for von Willebrand disease about the binding studies and so, which is more accurate and easier for the lab to be done than the previous testing for those patients. Now, a crucial issue when we talk about our friend in the hematopathology to diagnose a case of von Willebrand disease, which level we will depend on, 30, 50? So till this guideline came out, we didn't know how to diagnose it. Anyone who has von Willebrand factor more than 50, he is not a von Willebrand disease. We know that. Now, the problem coming when they have lower side. Well, okay, we start to think that this lady, she is during her menstruation and her von Willebrand coming down due to that reason, so we cannot say that this is von Willebrand or no. Now, with this guideline, we said that if it is less than 30, this is von Willebrand disease. Done. If it is less than 50, but they have bleeding steatosis, that means this is again von Willebrand disease, and that's it. Made the life easy. This is the flow chart how to diagnose von Willebrand disease and the types of von Willebrand disease. I may take 1 hour to explain this slide, but I'll bypass it. This is the type and what the type of test, sorry for the quality of this slide. And each one, what is the nature of the test, which will go for those. Tell you the truth, as hematologists, we do not depend on this graph anymore. We go for von Willebrand level, BFA, and the type 3 is easy to be diagnosed. Then forget it and go for WES, and that's this is the diagnosis. I'm not sure if every hematologist agree with me. This is what I said about factor that affect the von Willebrand factor level. Really, it is unimportant. For example, when you have a child, and this is the usual, I am a pediatrician by the way, when they are going to extract his blood to do von Willebrand level, and he is keep crying, and then his von Willebrand will go up. So it will be normal von Willebrand factor level, which is not true. So this one factor. When we go for the ladies, the menstruation, estrogen, pregnancy, blah, 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 all these factors does affect the von Willebrand factor level is say. So that is why I said, whenever you do von Willebrand factor and you find it normal, does not mean it is normal. Now, with the new guideline, if it is below 30, this is von Willebrand, forget it. If it is below 50 and he has bleeding, this is von Willebrand, and forget it. Now, if he has no bleeding, nothing, and it is more than 50, and you still have doubt about it, still you need to repeat it once more for your test. From management point of view, we do not have in Saudi Arabia the DDAVB, which is very important medication for the von Willebrand disease. It increased the level, particularly when we talk about the type 1 von Willebrand disease. It is not the same DDAVB where we are using by our friend in the endocrinology. It is special preparation, and it has shown that the von Willebrand factor increase in the level after a dose of DDAVB. Of course, we need to do test dose while the patient has no bleeding, just to be sure that it is working at this patient. So this is the way we are doing the testing level, and there is many form about the DDAVB used in von Willebrand disease. Keep in mind, after some time you are using DDAVB, you will go for tachyphylaxis, and it may not be working anymore. Now, the best thing is the von Willebrand replacement therapy, von Willebrand concentrate, either the plasma von Willebrand concentrate, where it is available in most hospitals here in Saudi Arabia, either in form of humate P or Willate, or the recombinant type, which is not available in Saudi Arabia. Cryoprecipitate as alternative. FFB, I don't like it, but you can use. And this is a list of the companies manufacturing von Willebrand concentrate, and what is the amount of the factor VIII functionality, which is very important to measure it. I'll come to that point. We need to think always about the safety and activity. When we talk about safety, of course, most of us, we are using the plasma type, so we need to take care about the matter of purification, because some of them pass into two steps purification, some of them none, nanofiltration, blah, 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 all of this safety. The other one is the activity of the von Willebrand factor plus the von Willebrand, factor VIII level. So we need to take care when we are treating a patient, particularly those whom they have serious life-threatening type of bleeding, or they go for major surgery. This is the humate Willate alphanate, which is available in Saudi Arabia, and this is what is going with each type of them. Keep in mind, some of them, they raise the factor VIII constantly while you are using those medications, so we get worried about the thrombosis. This is the dose, usually 20 to 60 unit per kg. We divide the patient about the major bleeding, major surgery, minor bleeding, minor surgery. Depending on that, we give a loading dose and maintenance dose, and how much of time we continue. In major surgery, we need to continue for 1 to 2 weeks with high dose, and keep measuring the level of factor VIII, not to go for thrombosis from safety point of view. سامي أخذ الميكروفون معناها لازم أغلق. Okay, now we need to have a measure for 0.5 at least to be in safe side for major surgeries. For minor surgeries, we go lower doses and lower duration. And again, we need to keep in mind the frequency. Tranexamic acid, which is available in every hospital, cheap and very effective among the von Willebrand type of bleeding, whatever the type of bleeding is. Topical agent, it is again, sometimes it's only medication needed for some of patients. Secondary prophylaxis, we are trying with some patients. Sami, he has a couple of patients, they are on prophylaxis. I have some of them, and it is really effective among those patients, and it has been proved to be a licensed way of management of the von Willebrand disease. Women with von Willebrand disease, they are suffering with menorrhagia and heavy menstruation. I'll not go over those details. It's a lecture by itself, but we need to take care of those ladies when they have heavy menstruation and von Willebrand disease, and managed with hormonal therapy in a way or another. Thank you.
Thank you, Professor Ahmed. You are exceed our time by 15 seconds only. And a great job. 15 seconds. Thank you very much, Professor.أحمد, for your excellent presentation. Actually, it's my pleasure now to introduce the second speakers, and she's going to talk about one of the commonest topics we face in the pediatric age group, thrombocytopenia in a critical ill child. My second speaker, distinguished speaker, د.هديل from Kuwait. She is president of Gulf Hemostasis and Thrombosis, and also she is graduate from McMaster University from Canada, and she is well-known speaker in national and international. And welcome, Dr. Heidel.
Assalamu alaikum. Thank you, Dr. Sami, for your nice introduction, and thank you for the organizing committee for giving me this opportunity to be part of today's activity. Today I'm going to talk about thrombocytopenia in critically ill children. Okay, so from the topic, dealing with the thrombocytopenia, we need a Google map to reach the end of the impact of thrombocytopenia on critically ill children. So today through my presentation, I will talk about the definition of thrombocytopenia, the mechanism of thrombocytopenia, the causes, differential diagnosis, symptoms and signs, treatment, and of course, we have to stop on the impact of the thrombocytopenia on critically ill patients. So from the topic, if we are talking about thrombocytopenia in critically ill children, by definition, the normal platelet count is between 150 to 450. So whenever we have dipping or dropping from those levels, then we will label the patient as thrombocytopenic. And thrombocytopenia, we have 3 levels. We have the mild, moderate, and severe. For the mild one, it's between 100 and 150. For the moderate, it's between 50 to 100. And whenever the level below 50, then we will label the patient as severe thrombocytopenic. The second part of the topic title is the critically ill patient. Then we are dealing with those patients who landed in the intensive care unit, whether for pediatric or neonate. Regardless, the subspecialist being, the patient have been under follow-up by the cardiologist, neurosurgical, hematology, GI. So the causes varies and the subspecialties varies between those cases. Or sometimes the patient will be landed just in the casualty, and from there he will be shifted to the ICU, and sometimes simply after trauma. So time of onset, around 35 to 45% of ICU patients, their thrombocytopenia will be just prior to their arrival to the ICU, or some of them will be after being admitted to the ICU, like within the first week of their admission. So dealing with those cases like, thrombocytopenia, we need to understand the causes, symptoms, diagnosis, management as well for those thrombocytopenia is crucial, so that will provide timely and effective care of these patients. For the intensivist, dealing with those cases, they need to know the causes for their patients and critical illness or developing complication through their stay in the ICU. So since we are talking about thrombocytopenia, we know the platelet to play a major role in hemostasis. I will take you briefly through this slide about the major components of hemostasis. As we know, whenever we get a vascular injury, that will initiate the vasoconstriction at the site of the injury. And from there, collagen and von Willebrand will be secreted from the endothelial surface, and that will activate the platelet. Activation of the platelet will promote the adhesion steps, and from there, the platelet cells will accumulate and form platelet plug. And by that, we reach the aggregation, which form the primary hemostasis. If we are talking about the second step of the hemostasis, then we are talking about the secondary hemostasis, which initiated by the tissue factor, in which it stimulates the coagulation cascade. I will not go through the coagulation cascade, but we know it will be ended up with fibrin, and that's what we call it the secondary hemostasis. So by the primary and secondary, we ended up by forming the blood clot. From here, from this slide, we see the importance of the platelet as a primary hemostasis steps in forming blood clot and preventing our body from bleeding and losing blood. And it depends on 2 issues, the platelet count plus the platelet function as well. sorry. So why it's important? Why do we talk about the thrombocytopenia today in our agenda? Because its prognostic significance, increased bleeding disorder for those cases will increase their risk of bleeding, longer stay in the ICU, and it has been seen through many cohort studies that the higher mortality in the ICU for those cases with thrombocytopenia would reach 30% compared with those without thrombocytopenia, which is half of the cases, around 15 to 20%. Longer duration on mechanical ventilation, plus minus, we have the prognostic marker of severe physiological stress. For example, those patients have a higher MODS, multiple organ dysfunction syndrome, plus higher or critical illness severity scores being recorded for some cases. So the gradual decline of platelet count is an early sign of impending complication, for example, RDS or renal failure or whatever. Mechanism of thrombocytopenia. We have a multiple mechanism can explain the thrombocytopenia. Again, back to the Google map, we have multiple stops, like it could be increased consumption, like we have a DIC or sepsis, or we have a liver or renal dysfunction that will affect the consumption of the platelet. Or simply we have impaired production. We have a defect in the bone marrow, like bone marrow failure, or it's being affected by hematological or non-hematological like problems. Or we have sequestration, for example, splenic sequestration, or sometimes by using other devices. We know those patients who landed in the ICU are connected to catheters or dialysis or ECMO in some cases. So we have immune-mediated, one of the mechanisms, like we have an ITB or NATE or drug-induced, or even adherence and aggregation in cases of sepsis or hemolytic uremic syndrome. Or simply, we have a defect or inaccurate sample, the sample volume or the storage, or sometimes the tube, or even the lipomic sample will give you false positive results for thrombocytopenia. So back to the causes for those thrombocytopenia in critically ill children, we have sepsis and infection, like those will affect the consumption of the platelet in those cases, or simply, as I said, bone marrow suppression, like leukemia or aplastic anemia, or sometimes with a drug-induced thrombocytopenia, for example, anti-epileptic, the most common one, and vancomycin. DIC can occur like post-thrombosis or simply after like infection or inflammatory process, or other underlying like causes, for example, ITB, HET, or mechanical factor, as I said, ECMOs or dialysis or catheters. So the symptoms and signs varies. Since we have like a defect in the primary hemostasis, then we will end up with bleeding. The bleeding, it's either mucocutaneous, like petechiae or bruises, or sometimes like epistaxis or hemoptysis, hematemesis, or organ hemorrhage, like the most common one, the intracranial hemorrhage, which we would like to avoid in such cases, and as well GI bleeding. The treatment varies in those cases. So either we have to treat the underlying causes, for example, if we have infection, or if we have sepsis, or if we have a drug-inducing thrombocytopenia, so we can simply treat those issues by either discontinue the medication, initiating antibiotic, consulting the ID for such a cases, or sometimes we need to treat the underlying causes, like in case of leukemia or other autoimmune disease. Supportive care will be indicated in some cases, like by giving platelet transfusion, and we have to consider the type of platelet, volume, frequency, and response, and management of bleeding in some cases that they might need blood transfusion, and sometimes supportive care, we can initiate or starting prophylaxis antibiotic just to prevent any infection initially with some cases. The medication, it varies, like we have the antibiotic whenever we have any infection or sepsis or DICs. Platelet transfusion, corticosteroid can be used in some cases, as well as IVIG. Back again to the treatment challenges. If we are talking about treatment challenges, whenever we have like a case with thrombocytopenia, then the thrombocytopenia will affect the involving invasive procedure, especially those landed in the ICU. We cannot insert line, we cannot, even with the ET tube, sometimes they will bleed easily. The prognosis, thrombocytopenia can worsen prognosis by increasing the risk of severe bleeding and prolonged stay in the ICU or in hospital in general. And also the complication varies between increased risk of bleeding or organ dysfunction, as I said earlier, the MODS, or thrombotic complication, or even landed up with impact on intervention. It's back to the treatment challenges that we cannot have any maneuver with those cases with thrombocytopenia whenever they have low platelet count. So magnitude of the drop of platelet count and non-improvement of thrombocytopenia are a strong predictor of mortality for those patients, especially in the ICU patients. There was a paper published, like many papers have the similar let's say, goal or objective. It was about association of thrombocytopenia and mortality in critical children, ill children admitted to PICU in tertiary hospital. That study from Nepal. And the case was prospective paper and over 12 months, including 102 patients, but 2 patients being excluded initially because of financial issues. So the total patient being involved within a year were 100. And through their study, they were measuring the platelet count at the day of admission to the ICU and then following 4 days of their admission. It have been found that the thrombocytopenia on the day of admission was on 16% of the total and increased to double by 34% by the coming 4 days. And the mortality among PICU patients during that period was 27%, but surprisingly that 61%, like more than half of them, were related to thrombocytopenia compared to only 7% with no thrombocytopenia being measured for them. So from that study, the conclusion was highlighting the significant association of increased mortality with those patients with thrombocytopenia compared with those with non-thrombocytopenia. So this is slide especially for those doctors who are covering the casualty or emergency room. So whenever you have a new patient presented with platelet count less than 100, and he is asymptomatic, you can just repeat the sample because it's most likely like an artifact. Or sometimes if you have acute drop of platelet, like more than 50% in the 24 to 48 hours, then you have to consider drug-induced ITB or HET. If you have a history of surgery less than 3 days ago, then you can think about post-op drop. If you have clear evidence of sepsis, like you have a culture that's positive for such organism, then you have to think about sepsis-associated thrombocytopenia. If you have abnormal coagulation profile in such a case, then you have to think about sepsis and DIC. If you have a blood contact with devices like dialysis, cardiac assist device, or ECMO related, so that will be related to the thrombocytopenia will be related to it. If you had a blood film shows microangiopathy, then you have to think about thrombotic microangiopathy. If you have a large amount of fluid being given, like resuscitation or dehydration, like you have given many boluses for those cases, then you have to think about hemodilution of the results, and you have fake false thrombocytopenia. It wouldn't be diseased one. If you have recent extensive thrombosis, then you have to think about clot thrombocytopenia, ended up with a recent blood transfusion, then you have to think about post-transfusion purpura. This is a quick key messages for those who are covering or dealing with those cases presented with thrombocytopenia. Since we've been mentioning thrombosis in many slides, this is a brief slides summarize the thrombosis in some cases. We know that venous thrombosis is very common in L patient or whether in ICU or in the ward. So the anticoagulation with low platelet count, what do you think about it? It's always like we will think about it, should we or should not? I know it varies between the cases, but we have to approach, like whenever we have a platelet count over 50, we can anticoagulate, like let's say a little bit safety compared with those like they have 30 to 50 their count of platelet, then we have to think about giving half of the dose of the anticoagulant. It depends about the case scenario and the case of the patient and his general condition. But whenever we have platelet count below 30, we will not initiate any anticoagulant. Again, those cases or those scenarios varies between the cases, and the severity of the thrombosis varies between those affected patients. Focus on the platelet transfusion. I know this part should be covered by the transfusion physician, but I will just highlight like the optimal timing and indication for platelet transfusion remains subject for debate. Like we cannot judge like 100% on our decision for such case. But let's talk about the general indication for a platelet transfusion. Then we are talking about active bleeding, low platelet count, let's say below 10 will be an indication for a platelet, though it varies between pediatric and a neonate. And if we have underlying condition like DIC will be one of the reasons to transfuse them. And we know there is a risk factor or risk of platelet transfusion. The most common one is the allergic reaction, Trally one of them, and infection as well. And I think nowadays we don't have the infection issues with the platelet transfusion. Consideration of platelet transfusion should be, we should consider the platelet quality and the platelet storage, plus the transfusion practice. We have to warm the platelet before giving it, and we have to make sure about the storage, and we have to think about the age of the platelet being stored in the blood bank. The decision to transfuse platelet in critically ill children should be made on case-by-case basis, so we will not form like a generalized guidelines or indication for all cases, so it varies between cases. This table, I wouldn't take it like seriously on my daily practice, but just to compare the platelet threshold between the neonate and the pediatric, though again, I do believe that in the neonate situation, we have other practice for a platelet transfusion whenever we have an early thrombocytopenia and late thrombocytopenia, and we have the first week, second week, and later on. So it still varies, and the level, sometimes they will consider below 50, below 30 to be the cut form or the cut threshold for transfusing patients. So still there is variation on indication for platelet transfusion between pediatric and a neonate. Thrombocytopenia, critically ill children, focus on the prognosis. We have severity of thrombocytopenia will affect the prognosis. Underlying causes like DIC or infection, it will make or it will be associated with higher mortality rates. If we are talking about the presence of bleeding, again, that will give a significant risk of mortality for such a case. Other comorbidities, if we have other like severe sepsis or other conditions that will worsen the prognosis, ended up with a response to treatment. Those patients response to treatment, including platelet transfusion and management of the underlying, can influence their outcome in general. Since we are dealing with thrombocytopenia, this is my last slide, then we need an MDT for such a case. We need an intensivist, we need the hematologist, we need the blood transfusion lab to be involved. ID in some sepsis or infection cases, ended up with radiologists whenever we are thinking about any thrombosis in our cases, like in general. I think by this slide, I reach my end of my presentation. Those who didn't visit Kuwait before, this is د.رقية, the most famous place, highly recommended. If you visit Kuwait, حياكم الله. And inshallah, the next meeting will be in Kuwait. And most of you are most welcome. Thank you.
Thank you very much, Dr. Hedeil, for excellent and informative presentations. And actually, you give us 2 minutes earlier, you are finished. That's a great job. So for last speakers, for our hematology today, we're a little bit away from hemostasis, and we'll come to the sickle cell disease, stroke, or vascular accident in sickle cell disease. Our speaker is Muhammad مطلوب عالم. Dr. Muhammad is a pediatric hematology oncologist. He has graduated from Do University of Karachi, Pakistan. When I mention Dr. Muhammad, we have to mention research. We have to mention the authors. He's actually the author and chief editor of a book titled Practical Guided Pediatric Hematology. And also Muhammad is will be involved in a lot of review editor and researches. And he has a lot of presentation of his research in many symposiums, national and international. It's my pleasure to introduce Dr. Muhammad.
Thank you, Dr. Sami, for your kind introduction. And it's my pleasure to be the part of this educational activity. And I would like to talk today regarding the cerebrovascular accident in sickle cell anemia patient. So as we know, sickle cell anemia is one of the most important and most common genetic disorder overall in the world. And it's caused by the genetic mutation in beta globulin gene, and which causing the qualitative and quantitative defect in the hemoglobin production. These slides give us a broader picture of the hemoglobin genetic disorders in the worldwide. If you look at this pie chart, it's mentioning that the 5% of the overall population worldwide have some kind of genetic mutation in the hemoglobin. And out of those, around 60% is caused by the sickle cell and by the thalassemia. Around 6.4 million population having worldwide sickle cell disease. So we can see the burden of the sickle cell disease over the healthcare system. And it is scattered overall Africa, in the Middle East, and India also. If you look at the birth rate of the sickle cell disease in the American and African population, 1 in 356 birth is because of the sickle cell disease. And 1 in 13 African birth is because of sickle cell trait. So there is a huge burden of the sickle cell disease overall in the world populations. In addition to that, every year 0.3 million new births are happening with sickle cell disease, which is adding to, contributing to the more complications related to sickle cell disease. As in Saudi Arabia, we are not away from the similar pictures. This first part is actually extracted from the Saudi pre-marital screening program from the Saudi Arabia, which was conducted between 2004 and 2009, and is mentioning that 4.5% of total Saudi population have sickle cell disease. Out of those, around 95% is because of the sickle cell trait, and around 0.3% is because of the sickle cell disease. So we have a very high load of the sickle cell disease overall in Saudi Arabia. Mostly we have a cluster of this disease in the eastern province and in Jizan region, which have a highest rate of sickle cell disease. If you look at the prevalence of sickle cell disease in Saudi population, 1 in 364 birth having a sickle cell disease, and 1 in 24 birth having a sickle cell trait. So these numbers are the calculated number. We don't have the exact and true numbers, but these are the estimation, and showing that the sickle cell disease is very prevalent in our population, and it have a burden in our healthcare system. So coming to the neurological complication of sickle cell disease, which is the topic of my talk today, and there is a wide range of CNS complication can be seen in sickle cell, and linked with the sickle cell disease is starting from the simple and the chronic headache, which is the most common in pediatric and the adult population, and leading towards the very acute and life-threatening complication, which could be because of the ischemic or hemorrhagic stroke. So looking at the acute complications, we have a hemorrhagic stroke, we have ischemic stroke, seizure disorder, and posterior cerebral encephalopathy syndromes. Coming to the chronic complications, it could be because of the sequelae of the stroke, or it could be because of the cerebral vasculopathy, which is more common in the sickle cell disease in the form of moya disorders, in the form of occlusive cerebral vasculopathies, and it can also cause aneurysm and other vasculopathies. If we look at the other complications of the chronic complications, like volumetric changes, dilatation of the vestibular basilar system, and the fat embolism, which is also common in patients with sickle cell disease. This graph is showing us the percentage and frequencies of different complications in sickle cell. As we know, the vaso-occlusive crisis and the acute chest syndrome is the most common one. But however, we have our acute complication like a stroke, which is seen in around 2.2% of the sickle cell anemia patient. This is a systemic review and the meta-analysis of very high yield studies. They included the study of 31 high yield studies, and they concluded that the headache is the most common neurological complication is seen in the adult and pediatric populations. However, the stroke is caused by is also seen in around 4.2% of the patient. There are some vascular changes can be seen along with the seizure activities. Now coming to the topic regarding the stroke. We have a multi-center prospective natural study, which is a cooperative study of the sickle cell disease, and they reported that the 11% of the patients with hemoglobinopathies, especially hemoglobin SS, having 11% of the stroke. And these percentages are more commonly seen in patients between 2 to 5 years of age. And if we don't provide the appropriate treatment or preventive measures, the recurrence chances for the stroke is around 47 to 93% of the patient. This is just, again, showing a prevalence of sickle cell disease in different countries. In Brazil, it is the highest one. However, in North America, Jamaica, Nigeria, and Turkey, we have an incidence rate of around 8%. In Medina, the city of طراوه, they reported 10% of the sickle cell patient has a stroke. However, we have a recent study published from the Jeddah, which is mentioning around 16% of all sickle cell pediatric patients having a stroke during their lifespan. This study actually concluded, and just want to look at the mortality rate in sickle cell anemia patient, and they find that the most common cause of mortality in sickle cell disease is infection again. But however, they reported that the stroke is the second most common cause of mortality in pediatric population. So we can say that 10% of all mortality is caused by the stroke. What are the major risk factors? Previous transient ischemic attack, silent infarct, abnormal transcranial Doppler, and vasculopathies, along with the high WBC count, low hemoglobin level, and low saturation is the contributing factors for the stroke. This study is a very big study, and they point out the two main important findings. They included around 3,000 stroke patients from the American African populations during the 6-year period, and they find that 23% of all strokes is caused by sickle cell anemia patient out of 3,000 patients. Another finding which is worth mentioning here, in the non-sickle cell anemia patients, around 54% of the stroke is caused by the ischemic stroke. However, in the sickle cell disease patient, around 90% of the stroke is caused by the ischemic stroke. Coming to the management of how we can treat the new onset of neurological insult or deficiency in sickle cell anemia patient. So before just going to the topic, just let's review the definition of the stroke. The stroke is defined by acute neurological symptom, which will be persisted more than 24 hours, along with the abnormal MRI or neuroimaging findings. When we suspect the stroke, any patient with sickle cell anemia patient, if they are presenting with acute onset of any neurological manifestation, we should think about stroke. And what are those manifestations? If any patient is presenting with persistent or severe headache, which is not defined by any other causes, if patient has a cranial nerve palsy, if the patient have a speech defect, if the patient has visual problems, motor dysfunctions, altered state of consciousness, and seizure activities and behavioral changes. Any of these patients should be investigated for the stroke. What we will do next? The first and important thing is it should be reviewed immediately by the PICU team, emergency physician, along with the hematologist and neurologist. We have to start the acute neuroprotective measures soon to avoid and decrease the neurological insult that can be permanent, that can be progressive in time. And of course, we have to diagnose the stroke, and for the diagnosis, we need an MRI or some kind of imaging studies, along with further specific management for the stroke. So once we are suspecting the stroke in patient, we started the immediate evaluation by the appropriate physicians. We started the acute neuroprotective measures, and what are those acute neuroprotective measures should be initiated? I think our friends from the ER and the PICU is well aware about all these things. It is important to start this immediately because it can decrease the extent of neurological damage. And what are those measures? We have to keep the patient NPO. We have to keep the patient head end on 30 degrees. We have to optimize the patient hemoglobin and the platelet. If there is a deficiency, we have to correct the coagulation. If they are there, if patient has a fever or any sign of infection, we have to treat the infection. We have to treat the the fever by giving an appropriate antipyretic measures. Other measures which is important also to maintain the patient's euvolemic. Patients should not have a high blood pressure, and the patient's electrolyte should be corrected appropriately. I think this measure should be initiated when we have a suspected stroke, even before diagnosing the patient. It can be started in the ER. So once this other investigation will be parallel to the measures we are taking. So we have to do the CBC, looking at the hemoglobin level and the platelet counts. We have to do the coagulation workup, including PT and APTT, basic metabolic workup, and hemoglobin S is important because if we want to go for a further specific management of the stroke. So once we reach here, the diagnosis of the stroke is radiological. And the most preferred method for a radiological investigation is the MRI, diffusion-weighted imaging, which including the MRA and MRV. But most of the time, we feel that it's not the patient is critically ill, and we can't go for a long duration of this imaging. So sometimes, alternatively, we can go for a non-contrast CT scan. But definitely, if even we go for a non-contrast CT scan and it is negative, we have to follow up with the MRI. So what can be the possibility in the MRI? MRI could be normal, and they are showing there is no intracranial injuries. And if there is no intracranial injuries in MRI, then we might consider a transient ischemic attack. We will consider about the seizure, and we can consider about the hemiplegic migraine. If the MRI is positive, there are possibilities the patient has a stroke, or the patient has a posterior reversible encephalopathy syndromes, or the patient have a cerebral sinus venous thrombosis. These are the very typical MRI finding of all this differential diagnosis when the patient has an abnormal MRI. So we can see a filling defects in the case of cerebrovenous thrombosis. The press is a very typical presentation causing a defect in the posterior part of the cerebellum. In acute hemorrhagic and acute arterial ischemic stroke, they have a significant they have a very typical radiological findings. So we can easily differentiate among all these differentials. What will be the next step? So the next step is the management. What will be the specific management for the stroke? So if any patient who has a negative MRI, and we are suspecting strongly clinically that the patient has a stroke, or the patient has a transient ischemic attack, or the patient has a stroke, or any patient who has a superior cerebral sinus thrombosis or press, then the specific management will be same. We have to provide the patient oxygen transfusion, and the aim of this oxygen transfusion is to keep the hemoglobin S less than 30%, and we don't want to raise the hemoglobin more than 10. But most of the time, the oxygen transfusion is not possible to provide within a limited time. So if we are expecting a delay in the oxygen transfusion, the alternative methods to deal with this patient is a simple transfusion followed by oxygen transfusion. Of course, there is two other options we have. We have use of thrombolytic agents in the form of tissue plasminogen activator and use of antiplatelet agents. In case of ischemic stroke, there is a controversial and debatable issues that should we start the antiplatelet agents or thrombolytic agent. But in both of these cases, there is a problem that these two agents can aggravate the hemorrhagic stroke, or the patient with the ischemic stroke can progress to a hemorrhagic stroke. So the role of these two agents in case of ischemic stroke is controversial. Of course, it's contraindicated in case of hemorrhagic stroke. What will be the next after stabilization of the patient with a stroke? What we have to do, we have to repeat the MRI and MRA in 2 to 4 weeks period, looking at the progressive neurological deficit or the progressive nature of the infarct. And then we have to start the secondary prophylaxis, because if we did not start the secondary prophylaxis, there are chances for recurrence is very high. It's reaching up to around 75%. We have to review, send this patient to the neurology for a baseline neurological assessment, and they have to follow this patient according to their neurological findings. And rehabilitation is, of course, is required to improve the functional outcome. What are the prognosis of acute stroke? Yes, so we know usually the marked improvement can be seen after extreme transfusion. And if we did not start the secondary prophylaxis, the chances for recurrence is very high within 2 years. around 75% of the patient can have a recurrence of a stroke. And significant neurological deficit is more common after second stroke. We have very strong landmark studies regarding the prevention of primary and secondary stroke. These two trials, STOP1 and STOP2 trial is just focusing for the prevention of a stroke. And the STOP1 trial is a stroke prevention trial, and the STOP2 is the optimization of the primary stroke prevention. What was the conclusion of the STOP1 trial? They mentioned that the TCD is mandatory for all the pediatric patients between the age of 2 years to 16 years. And any patient who has an abnormal TCD, which means the transcranial Doppler reading is more than 200 centimeter per second, all patients should be started on chronic transfusion. The second study is also looking at what age or after how many transfusions we can stop the transfusion. So they saw that any patient who has a high TCD and we stop the transfusion, there's a recurrence chance is again high. So they are just recommending that any patient who has a high TCD should be on continuous transfusion for more long times. The another study is the SWISH trial. SWISH trial is a stroke with transfusion changing to hydroxyurea, and they are recommending that the chronic transfusion is more beneficial than the hydroxyurea in prevention of secondary stroke. The another study is a TWICH trial, which is looking at the patient who has an abnormal TCD, and after how many transfusions we can switch this patient from transfusion to hydroxyurea. And they are mentioning that the hydroxyurea also have an equivalent safety and prevention of secondary stroke. If after giving an appropriate transfusion, it can be shifted to the hydroxyurea. We have another trial, it's called SIT trial. SIT trial is a silent cerebral infarct with transfusion, and this study is also supporting the use of chronic blood transfusion for patient who has silent ischemic stroke. So what are the primary stroke preventions? We have three options. We have the transcranial Doppler should be instituted in all sickle cell anemia patients from the age of 2 years until 16 years and should be done annually if the patient has a normal TCD. The other option is the regular blood transfusion, and the third option, which is now the standard of care for all pediatric patients, should be started on hydroxyurea by the age of 9 months, irrespective of any genetic mutation, any kind of genetic variation. So we have a study from the American Society of Hematology, and they are recommending that all the patients should be followed up by the transcranial Doppler. And this study is based on this finding of the STOP trial. The STOP trial is mentioning if any patient who has TCD finding more than 200 centimeter per second, they have a chances of recurrence annually is around 9%. So by the end of 3 years, 30% of the patient can have a stroke if the appropriate preventive measures is not taken. So any patient who has an abnormal TCD, transcranial Doppler, so we have different techniques to measure the transcranial Doppler. We have image-based ultrasound and we have a non-image-based ultrasound. And there is a different cutoff among those. So any patient who has more than 2 readings of more than 200 centimeter per second or a single reading of around 220 centimeter per second by non-imaging technique, or any patient who has an imaging TCD and the reading is more than 180 in 2 readings, or if they have a measurement of single reading which is more than 205, then it is considered as an abnormal TCD. So once we have an abnormal TCD, the option is the American Society of Hematology is recommending to start the chronic transfusion, which should be around 3 to 4 weekly, at least 4 years, to maintain a hemoglobin S less than 30% and to maintain the hemoglobin more than 9. The another option is if the chronic blood transfusion facility is not available. So we have an alternative options to provide a maximum tolerance dose of hydroxyurea, at least at the range of 20 mg per kilograms per day. And if the patient is started on the regular blood transfusion after a certain period, which is around 1 year after the transfusion, the patient has a stable TCD and no neurological further manifestation, we can safely switch this patient to the hydroxyurea. And this is a pool analysis, just giving us an idea that if we start the hydroxyurea and it's given for 3 months, we can see the decrease in the transcranial Doppler by 29 centimeter per second, which is ranging around between 15 to 29 centimeter decrease in the TCT. So we have a secondary prevention to prevent the secondary stroke. We have a regular blood transfusion, hydroxyurea, and hematopoietic transplantation. In the top part, we can see the hydroxyurea is very effective, decreasing the secondary stroke, and is pulling the data towards 0. And similarly, the transfusion also very effective in preventing the secondary stroke transfusion. And without the hydroxyurea and transfusion, we can see around 25% of the patient can have a secondary stroke. So we have a few studies just looking at the pre and the post intervention decrease in the secondary stroke, and all these are the very powerful studies mentioning that if we start the hydroxyurea, if we measure the transcranial Doppler, if we start the chronic transfusion, 90% of the patient's stroke prevalence can be decreased by these interventions. So I will conclude my presentation here with recapping the presentation. The cerebrovascular accident is one of the leading causes of morbidity and mortality in sickle cell anemia patient, and any suspected cases should be immediately seen in the ER and the PICU physician, along with the hematologist and the neurologist. Management includes acute neuroprotective measures, neuroimaging, especially the MRI if it is available. Extended transfusion is the preferred method of transfusion. If it is not available, then simple transfusion followed by extended transfusion is another option. Use of thrombolytic agents and antiplatelet agent is controversial. And for primary prevention, we have a hydroxyurea, we have chronic blood transfusion, and for secondary prevention, we have a chronic blood transfusion, hydroxyurea, and in selected cases, hematopoietic stem cell transplantation is one of the options among them. Thank you so much for your attention.